biggest thing is we all start somewhere. So when I go out and train doctors on documentation, like I don't challenge them medically. I just say,
what would you say are your main fields?
My main thing usually is getting time with the doctors when I go into a new organization, because
how many provider offices did you work on once?
I had a contract with a group in California where I would visit 79 offices every 2 weeks.
How did you see this process evolving?
You see in our industry, they have very good systems, but I don't think the people aspect is going to change. Because
where do you see the future of risk adjustment?
Risk adjustment is good for documentation, and it's really about managing those patients.
Welcome to today's episode of Healthcare Journeys. Before introducing today's guest, just a reminder to follow S2M Health on LinkedIn and discover new episodes in your feed. Today's guest is Ryan Dodson. With a background in management and operational processes for more than 20 years and in risk adjustment for 15 years, he's the Chief Operating Officer and co-founder of New Vision Healthcare Solutions and founder of Dodson Consulting. Thank you, Ryan, for joining us today.
Thank you very much for having me.
I'm so excited about this conversation. You're obviously a very recognizable face in the risk adjustment world. We all know you, so I almost don't feel that introduction was useful because people know who you are very well and can identify you because of the hat.
Yes, ma'am, the hat.
In your logo. But I'm so glad that we're having this conversation. We always meet at conferences, and you're heading to one conference soon, right?
Yes, the RA Forum starts on Sunday in Louisville, Kentucky.
Awesome. All right. We'll probably see you there. All right. So let's get started with this conversation. We have a lot to talk about. One of the things people may not know about you, because we usually don't talk about our backgrounds in conferences, but how did you get first started in healthcare? Like what drew you to this area of?
So I used to be an airline supervisor in Atlanta. And then when I got married, my wife at the time was an MA. And we moved back from Atlanta to Bakersfield, California, her hometown. And she's like, I'm like, I can't find a job here. The airport's like this big. What am I going to do? And she's like, what do you mean? I was like, I worked at Hartsfield, the busiest airport in the world. And we have more flights and people go out of our gates in one day than you have in 3 years. I'm like, so I don't have anything to do. She's like, oh, well, we have this new program at work. It's called risk adjustment. She goes, you're smart. You'll figure it out. And so they interviewed me. And then based on my operational background, they hired me to be an HCC auditor, a coder.
Wow.
And I learned how to code. I learned how to visit with doctors. I studied risk adjustment. I attended all kinds of conferences and webinars to learn risk adjustment. And then within 6 months, I was running the department. And I moved a group of 10,000 seniors RAF score from a 0.979 to a 1.473. And using provider education and clinical documentation improvement audits.
Wow. So you learned it on your own. It was an opportunity that came up. You learned it and you liked it, obviously.
I just kind of fell into it. And then when, I moved to some different groups. I worked on the vendor side. I worked on a couple of different health plans. I worked for them. And then a couple years ago, right before COVID hit, Molina Healthcare offered me an opportunity to move back to Texas, where I'm from. Mm-hmm. And then COVID hit. And I said, you know what, I'm going to open my own company. And that's when I started New Vision Healthcare Solutions. Mm-hmm. And we've gone from the first year we did about 5,000 or 6,000 charts. And then last year we did about 450,000 charts.
Wow. That's a big jump. And you also do other type of consulting, right? Like it's not just risk. I see you conferences as a speaker, right?
So I've been very lucky. I've been on the Rise speaking circuit for going on 13, 14 years. I do a lot of speaking for them. I do speaking on quality. I do speaking on provider engagement. I do speaking on customer service. And then I chair some conferences, or I'm my track chair. Like I'm a track chair in Arizona for the STARS Masterclass. And it's just a good community because you meet people and they kind of become like family, and you can always lean on them if there's some question. Like, so if I have a question about that I can't answer about risk adjustment, there's certain other experts in my field that I can just call and be like, hey, let me ask you a question. The same as they know is that they have a question or they're unsure of something, they can call and ask me. And it's not like a consulting thing. It was just like basically a kitchen cabinet where they can call and say, hey, Claudia, I thought about this. What do you think about that? Or do you think this is not something we should try to do? And then you can give us what your feedback is on it. And we're like, okay, we're going to try this. We're not.
I think it's a great community. And it's so interesting that because it's such a niche, people who are in the industry, I'm surprised still know each other. It's pretty interesting. It's almost like a high school reunion. Everybody's friends with everybody, and it's a great community. So you
can see people move around from different companies.
Yeah, that's another thing. Yeah, like
when I got started and I first met you, I think I was at the medical group.
Yeah.
The next time I saw you, I was at a health plan.
Yeah, same here. You kept moving. Yeah.
Like, what are you doing? And then people will call you. I mean, it is a very the risk adjustment community is very small. So people call me all the time for they'll call me like, hey, I see you work to the company with this other person. What do you think? Because we all know each other. I mean, I've been on calls where I've had to do audits and I get on the call and they're like, hey, Ryan. And I'm like, hey, so we were wondering where you were at. And I was like, oh, yeah, I work here. I consult with this group. And, but it's just a small community. Like I was on an audit call the other day where they wanted me to look at an audit. And the person from the plan, I had known them for like 15 years.
Right. Well, that's another thing. I think, I've known people that are part of the industry that are not as connected as you are. So I think it's also your personality to be a connector, right? Like you are one of those people that I think you connect people, right? You connect ideas, you connect like, oh, someone else talk about that. Let me put you in touch with that person. You're very like that. You like to share. You don't have that corporate barrier,
right, because there's times people come to me and they're like, hey, so like one of the things I started doing at the RISE conferences was going around to all the vendors and learning what they did. Because if one of my clients comes to me and is like, hey, Ryan, we need a new analytic tool. I don't do analytics, but I can go, okay, here are the people that I know in the industry. This is what each one they provide. Now you can go out and make your own decision. I'm not telling them who I would go for, but I can give them information on the different companies and then they can make a decision. Same as if like somebody came to me and they're like, hey, I need 100,000 charts done in 2 months. I know my company's not big enough to do that. So I can go to another company like you guys and be like, hey, I need some help. Can you help me with this audit? And we can get it done.
Yeah, I think that's part of your personality, that you don't have that barrier. I think a lot of other vendors are like, well, I'm not going to tell you anything. I'm like, okay, well, we know even within the industry, companies work with competitors even sometimes. Like they source work to competitors and, behind the scenes. And health plans may not know this, right? Like, but companies do partner to be able to offer a full solution in most cases. So let me ask you this. So let's go back to the beginning again, because this is who you are now. This persona, you go into company, everybody knows you. But how did this came to be? Because you told me you fell into this work, started the work, but not everybody can get to this level of recognition. How did you first start and say, or intentional, which say like, I want to be in the conference circuit. I want to be a speaker.
So one of the original RISE conferences was in Nashville. And I got an email from somebody like, hey, we have a $99 pass, but the conference is in like 3 days. And so, me working for an airline, also being young and being like not the brightest bulb in the bunch at that time, I took the $99 pass and then I took the red eye out of LAX and landed in Atlanta at 7:00 in the morning. Wow. The conference started at 8, and it was like really small, but I learned a lot. And so then I looked up another conference. It was a competitor. and it was in Jacksonville. And I went to that. I met a lot of people, but then I started asking questions when during the question and answer session. And just so happens during the question and answer session that the conference producer was in the room, and she came up to me and she's like, "Hey, you seem to know a lot about this. We would like you to speak at our next event."
Oh, I see.
And that's how I got my start. I mean, I kind of just lucked into it. Like I was in the room asking questions, and she's like, "Hey, we'd like you to talk." And then, I started speaking at RISE conferences. I speak at all the risk adjustment ones. And then they started adding me to the quality ones and the member engagement ones to do different things because you bring a different perspective. And then even to now, I play Santa every year at the STARS Masterclass and the Women's Conference in Arizona in December.
Awesome. See, I think it is intentional. I think that, and also it's part of your personality. It comes natural. So I think that's helped a lot, right? Like some people, they won't be as confident to ask many questions during the Q&As, or dress as Santa for some of these conferences, but you do. So I think your confidence, has helped a lot, the
biggest thing is we all start somewhere.
Yeah.
So, I always, when I go out and train doctors on documentation, like I don't challenge them medically. I just say, "Hey, I'm going to show you from a coder's perspective what I'm looking at. I'm going to make suggestions. You are the clinician. If you medically don't agree with it, don't document it." I'm just teaching the CMS guidelines and how it should be documented. Now it's up to you whether or not you do it or not.
I think
that's some ease.
That you are just trying to be helpful, right? Like, and that without imposing. And I think that's also.
Yeah, and that's one of the things in our industry you have to learn. Like you have to learn to read the room. So like if I walk into a doctor's office and there's like 30 patients in the waiting room, even though I have an appointment, I just leave my card and say, "Hey, tell doc, take care of these patients. Give me a call when he has time." You learn to read the room. If the doctors are behind, it's not a good time for you to spend. They might have to work through their lunch to catch up. Why are you going to take up their time and put them even further behind? And doctors appreciate things like that, and they remember it.
That's right. So now that we're talking about some of the work you do,
you've been in risk adjustment for a while, doing this work, and you've experienced the changes.
What were some of the unexpected experiences or surprises that you found in your work? Like some moments that have impacted your approach, something that was surprising.
When CMS decides to change the rules.
Yeah, but that is not surprising, was it?
They changed the rules in the middle of the game. So, you have to adjust to that. You also have to adjust to new providers being brought on or new leadership, whether or not it be at the plan or your group or, things that break. And you just have to be able to be fluid in what you do. Yeah. There's not a hard line with everything. That's one of the things I learned working at the airline industry is like you couldn't control the weather. And so if it was bad weather, your planes were going to be delayed. You just had to go with the punches and make it done. So that's what I do with clinicians when I'm working with them. I know when I go in and they are behind, or I know when they are having a hard day. I always tell, when I'm training new people on how to work with doctors, I tell them, I'm like, watch their eyes. You can read their eyes. If their eyes start to glaze over, they're not paying attention. Just wrap it up. I said, and the minute they pull out their phone or their tablet, I'm like, they're not listening anymore. You're just blowing hot air and they're not going to listen to it. I said, learn to read the room and be able to say, "Okay, hey doc, this is not a good time. Let's make another meeting maybe in a week or two when you have more time."
Well, and also what you say, I think that you also need to, and by what you're describing, you must be really good at teaching things, right? Like at teaching other people. Because I always, when I sit in some of these conferences and I, listen to very dense information about CMS rulings or like pharmacy or, different conferences I've seen presentations that had a lot of slides and a lot of information. It's an art to teach these topics, lots of acronyms, different rules and regulations that are extremely complex. Like, it's not something you find every day. So I think that having that skill to teach is important, and you definitely have.
I tell people half my job is to be a comedian,
Yeah,
because these things, this subject's very boring. Like you said at the conferences, when I do a conference talk or when I do a presentation, I try not to read my slides.
yeah,
The slides are up there as background. My job is to present a key fact, and ultimately what I'm looking for, especially in risk adjustment or quality, is give them something that they can take back to their organization and try to implement, that will create an ROI, that will prove to their leadership, like, oh, it was very important to send Claudia to this conference because she brought back this idea that netted us a 1-star gain on a measure, or she brought back an idea that increased our RAF score by 0.75 in this metric.
yeah,
And if you tell them stuff, I always tell them, like, if you tell them stuff that makes them laugh or makes them remember, they will remember that when they are documenting.
right. Yeah, I think that is a skill also, right? Like teaching with humor, like you do concepts that are so complex, and also people forget. I mean, it is really dense information sometimes. I see people taking notes in some of these sessions, and just there's a lot of information, and you definitely have a style to make sure people remember the concepts, right? I have a question about your business. So,
Okay.
like you've mentioned, running risk adjustment, comes with challenges. You mentioned the CMS changes. Um, Obviously, is one of them, right? Like big challenge that things are always changing. There's a level of unpredictability there. Um, what would you say are your main
Hurdles.
How do you tackle them? Like your business, as you're running your business.
So my main thing usually is getting time with the doctors when I go into a new organization, because they don't know me per se. Like the doctors that I worked with for years, all I gotta do is make a text message and they'll make time for me no matter what. But like if I'm going into a new organization, I gotta explain to them what I'm there to do, and how I'm there to help them. So we go by and you just explain to them, like, hey doc, I'm not here to make your life easier. I'm actually trying to make your life make your life harder, trying to make your life easier. So this is what we're going to do to help you set forward. And then what I also try to do is take a look at their operational processes as far as risk adjustment. Because like I've always, we had one doctor that we worked with, and his RAF score was high. It was like a 1.5. Well, the next year in July, his RAF score was like a 0.7. And I'm like, what's going on here? Well, come to find out, I went out and did an audit of his charts, and I looked at his claims. His biller was only submitting 4 codes. So all the risk adjustment codes pretty much weren't making it on the claims. They were all there and documented, but they weren't making it on the claim. And so we had to make that adjustment, and I had to tell them, like, hey, you need to talk to your biller. They need to submit all these codes when you do these visits. And if there's more than 12, you need to use this other CPT code to get the more codes in. I'm like, because if not, it's going to catch on the retro audit, which is not good. I said, so let's do it up front, do it now. And so, that's some of the things I look at. Most of the doctors I deal with, because of my nature and just talking to people, because I don't come from a medical background, I'm pretty easy to talk to them. But usually it's just getting time with them. So like I used to have a spreadsheet of my doctors where I would know when was the right time to go to their office. How is the best way to contact them? Is it text? Is it a phone call? Is it an email? And then I also knew, what did they want to drink from Starbucks? Or, what did they want from Jamba Juice? That way, when I came, I assigned to the philosophy is never come empty-handed. So if I'm going to come to your office and I'm going to do something with you, if I'm taking up your lunchtime, I'm bringing lunch. If I'm taking up time in the morning, I'm bringing breakfast. If I'm coming to visit you, unless I'm delivering a check, because nobody's going to turn down a check. But if I'm coming to deliver a message, or like, hey, I need you to do something in 5 minutes, I'm going to bring you a cup of coffee and be like, hey, doc, I brought you this coffee. By the way, I need you to do this, this, and this. Spend 10 minutes with them and be gone.
So this is very labor intensive, right? Like obviously you love your job, and so it comes natural to you. But if we start thinking, well, going into the provider office, eating lunch, bringing a drink, and actually after all of that, doing the work, teaching them, going through, it's a lot. So how many provider offices do you work on at once, like as a project? Do you have like an idea of how many?
So I had a contract with a group in California where I would visit 79 offices every 2 weeks. So
79.
every 2 weeks I would well, it was 79 providers. I would say it was about 50 offices because some offices had multiple providers. But I would visit about 50 offices. So I'd visit about 12 to 13 offices a day. I'd fly in on Sunday and I'd visit the offices Monday, Tuesday, Wednesday, and half the day Thursday and go home.
Oh, wow.
And what you do, you do an operational plan for that. So the way I set it up was driving around that community was I set it up as a circle. I would start at my hotel. I'd work my way around. I'd visit 12 offices. The next day I'd start where I left off, 12 more offices, and just do a circle and end up back at my hotel and ready to go out and then the offices would expect, okay, it's the second Tuesday of the month. Ryan should be here about 9:30. And 9:30, I would pop in.
This is a lot of work to like connect with people.
Every office
I'm sure.
has its own challenges too. How do you see this process evolving?
Right? Like, do you think this is sustainable long term, or you think, or do you think that this is it? Because some processes, even though we want to automate them, they're not. They have to be. The process that we're following currently is the best thing, so far. But how do you see this evolving now, more so with technology? Because I see a lot of point of care solutions, but I just don't have any data to validate whether point of care solutions are being highly adopted by providers.
I think a lot of vendors that we have and we've seen in our industry, they have very good like systems. They have very good analytics. They have very good point of sales. But I don't think the people aspect is going to change because you have to go in and basically handhold or talk to these providers and the office staff. The office staff is one of the most important things. I always tell people, make friends with your office managers. Because in California, 99% of the time it was the wife of the doctor or the spouse of the doctor. I had one doctor's group where the husband was the office manager, the wife was the DO. And I made really good friends with him. And whenever I need anything, all I had to do was text him. And he's like, yeah, I'll make sure she's available when you come in. If you make friends with them and treat them as something important, because if not, they're going to be the gatekeeper to the office and you're not going to get through that gate. So if you just learn to, include them and say, hey, I want to talk. Is this a good time? Because they'll tell you if it's a good time or not. Like if I walk in and I see an officer's manager's face and it's like all scrunched up, I know it's probably not a good time. And so I'm like, what can I do to help? And, that's the other thing too is, you can make suggestions, but at the end of the day, it's their office. Right. I can sit down and I can say like, hey, doc, here are the roadblocks in your office, or hey, office manager, here are the roadblocks I see. What do you think? And if you involve them in the solution, instead of saying, hey, here's the solution, do this. If you involve them in the solution, I find that is usually a lot better and gets the things off the ground. Like that doctor I was telling you about with his biller was just submitting 4 codes. I sat down with him and I said, this is your problem. How can I help you fix this? And he took care of it right away. And it didn't happen again.
So it's basically the people doing the work, their habits are going to be hard to break, right? Like it's teaching them how the work is done and that will have to continue, right? Even if they have solutions or not.
Right. So one of the things I did last year was I did a train the trainer program for a health plan in Rhode Island. And I went and I sat down with their leadership and their provider relations expert people and their analysts and their coders. And I said, okay, this is the art of training the provider. This is what I've done. This is what I've done that's worked. And then you take that and you just morph it into your own stuff. I just told them all the time, I was like, hey, you want to use some of my jokes? Go ahead. I'm like, you got to make it your own though. Like get these people on board, I said, and make them think that you actually care. You really care. Because I always tell people, like, there's a quote by, I believe it's Theodore Roosevelt that says, nobody cares how much you know until they know how much you care. And if you can go in and show that you're there to help them, not make their life harder, because if you think about it, one provider, he might belong to 5 different IPAs.
Mm-hmm.
And of those 5 different IPAs, there might be 7 different health plans.
Mm-hmm.
So how would you like for your office to come in and all of a sudden get 25 visits from different people? So what I did on when I worked for the provider group was I went to the plans like, this is my education, this is what I do, let me handle it. I said, I will take care of it. I don't need you guys to do it. And I went in and did all the education. I'm like, if you have any feedback that you want to give me, I'm more than happy to take that feedback. Doesn't mean I'm going to change it, but I will take your feedback.
I'll take it.
And I'll present it to the doctors. And the doctors like that. One of the things too that you run into where doctors get medical record requests and they get bombarded by medical record requests. And so I would tell my health plans, I'm like, don't send anything to my doctors. I'm like, my group will go out and collect the charts every year. We'll collect all the charts. If you need something, you come to me. I said, and then when you come to me, you give it to me. I'm pretty sure I've already collected these charts. I will send them to you. If there's some extra data you need, we'll go out and get it. That way we're not overburdening the providers' offices. And then providers appreciate that.
Yeah, you're managing the relationship with the provider, which I think it's really smart. We had recently a conversation with a different guest about how difficult the relationship with providers is. I think one of the reasons is this, right? Like they are overburdened. There are a lot of requests that come in, and people who are not in the industry that I mentioned this to, they're like, there has to be a better way to do this. I'm like, well, this is what it is. I mean, we're trying to improve it, but for now, this is what it is,
Like, for example, you take coding and annual wellness visits. You have 6 different plans. They have 6 different forms they wanted you to fill out. Or on my side, when I do coding, I'll do coding. Well, of the 6 plans, there's 4 different data file formats. Mm-hmm. They're all different. Nobody follows the same data file format. So it goes, Humana has one, Anthem has one, Blue Shield has one, Centene has something different. They're all different. And when I submit that data, I got to submit it in their specific file so it gets rejected. Wow. Imagine that being a provider office who's dealing with, all these different plans. And they just providers tell me, like, I didn't get into medicine to fill out paperwork all the time. I got into medicine to take care of the patients.
Yeah, there's a lot of administrative work that they need to do. A lot of companies and people like you who are trying to help the process and help them overcome all of the the struggles of their everyday. So I have a question about risk adjustment. Where do you see it going? Like, where do you see the future of risk adjustment? Because as we have this conversation, even to us, but even for people that may be in a different area of healthcare, they listen to this and are like, well, this is a lot of complexity attached to this process, right? So where do you see it going? Even more so now with AI and technology and the
CMS changes.
What I really see risk adjustment used for, and it should have been used like this all the way, is managing your patients to keep them out of the hospital. So risk adjustment is good for documentation, and what you can do is you can use it to better manage your population. So my session at the RA forum is on case management, the next frontier of RA. Because if you document everything correctly, then you can then push those people into case management. So you can take your patients who have CHF and COPD and, might be on home oxygen, you can follow them with case management. Mm-hmm. Is there something wrong? I mean, not to give away my talk in Louisville, but one of the things that one of the groups I used to work with did was they had an AC gun retainer. You think, well, why do you have an AC gun retainer? Well, when it's 120 degrees and you have COPD and CHF and that acerbates, you're going to the hospital. So would you rather spend $30,000 to go when they go to the hospital, or you want to spend like $3,000 or $4,000 to fix their AC unit? Even on the high end, it's $5,000 to fix an AC unit. That's 6 hospital admissions that you can prevent. And it's thinking outside the box like that. It's just managing the patients. I mean, I'm married to a nurse, and I've been on I've heard her take calls in the middle of the night for nurse triage, and sometimes these patients just want to be heard. And she can make that decision on whether or not they need to go to the ER or whether they need to wait the next day and go see their PCP, or they can go to urgent care. But that's how you manage your population. And you push those people into, the health programs. Like, hey, you have diabetes. You need to attend our diabetes education class once a month. Come here and we're going to talk about your diet. Or, you have morbid obesity. Come to our exercise class that we offer. It's low impact and, it'll get you moving. You have CHF. Come into our CHF class that we have every 2 weeks and learn about the different parts of CHF and what to watch for. And ultimately is getting our patients healthier. And then another thing I see us moving into is the social determinants of health. That's the new buzzword right now. But realistically, if you look at social determinants of health, there is so many things. Like, I did a presentation one time with Rick. Rick from United. Yeah, I did a presentation with them, and we talked about morbid obesity. And I was like, yeah, put a fat guy up on stage to talk about morbid obesity. I'm like, we're talking about morbid obesity in food deserts, where it's $2 to get a cheeseburger versus $8 to get a salad.
Right.
If you don't have it, if you're low income, what are you gonna do? What are you gonna do when you're shopping at a convenience store because the nearest grocery store is 10 miles away and you don't have a car? I'm like, that's the data we need in the United States to help better manage our population.
Yeah, I think SDOH 2 or 3 years ago was a buzzword, and the challenge was health plans and organizations were trying to find a way to capture that data, right? Like, sometimes it was organic data, anecdotal, like a care management call. Like, there was not a mechanism to accurately capture that data. So I think SDOH was kind of went into the box of like, okay, we don't know how to deal with this, and now it's coming back, right? Like with the health equity scoring, and like, okay, so now how can we revisit this? There are a lot of companies coming up in the care management space. I don't know if you noticed that, right? I think it's a thing that is getting revisited again. Like, people don't know the challenges of capturing that information from a member, right? Because it's multiple sources, multiple people touching one member, and not an easy way to gather and communicate that data across the patient journey.
Right, and then sharing data is what we need. We need to be able to share data. I go out and I educate physicians, and I tell them, like, hey, you can't count on a specialist to document this condition. Like, you're the PCP, you're the quarterback of care. Everything needs to be in your chart. Because if I walk out of this office today and I get hit by a bus, I'm like, they're not going to call all the specialists in all the hospital. They're going to call you, my PCP. And if everything's documented in that medical record, they're like, oh, I didn't know Ryan had CHF. My treatment method is going to be different for him.
Yeah. So my last question was going to be, how does your work in risk adjustment have influenced your views on patient care and healthcare outcomes? Which it seems to be like there is a lot of influence there, from your work into how the member care should be managed, right? It seems to me that you think risk adjustment should have always been tied to care management, right? More so than the risk adjustment just leaving on its own, as its own program. Yeah.
You got to break down the silos, and you got to do proactive case management. For so long, we've done reactive case management. So, I'm married to a case manager. And it's like, she's like, well, you talk about case management. What's the difference between what I do and what you do? I was like, well, honey, you do reactive case management. So once these patients get out of the hospital, you have them on case management, hopefully to make sure they don't readmit. I said, what I want to do is do proactive case management based on their documentation and their data. That way they never go to the hospital in the first place.
Right.
Because I see that as the shared savings in ACOs. I see that as the savings in shared risk and full risk groups. Mm-hmm. I worked for a full risk group for the longest time, and a lot of my clients are full risk groups. And it's really about managing those patients. With the RAF score decrease, you're going to have to manage your patients better and keep them out of the hospital.
Great. Well, thank you for that. It's been a great conversation. We could keep talking forever, but just for everybody to know, when we say RA is the Risk Adjustment Forum, and Ryan is going to be a speaker there. So if you're attending the conference, make sure to go to that session, which I'm sure is going to be great. Thank you, Ryan, for joining us today. As always.
Thank you so much for having me.
Yeah, thank you. And don't forget to follow S2M Health on LinkedIn. Until next time, thank you.